Everyone. Good evening, everyone. Thank you for joining us for the Epilepsy Foundation of Metropolitan New York's webinar tonight. If we're not acquainted, let me introduce myself. My name is Eleanor Latouche, and I've had the privilege of being the executive director for this organization during the last 16 months. So tonight, it is with great pleasure that I introduce our presentation, which is generously sponsored by LivaNova, a long-term supporter of EFMNY. Tonight's presentation is seizure detection using wearable devices, current and emerging technologies. We are most fortunate to welcome back two longtime members of our professional advisory board to conduct another relevant webinar. We have the renowned Dr. Stephen Wolf of Boston Children's Health Physicians, New York and Connecticut, Maria Ferrari Children's Hospital, New York Medical College Clinical Professor of Pediatrics, and he's part of the New York Medical Group. Also with us, we have Patricia McGoldrick, nurse practitioner, MPA, and MSN. She's the Director of Epilepsy Monitoring for Boston Children's Health Physicians, New York and Connecticut, Maria Ferrari Children's Hospital, and New York Medical College. I'd be remiss if I didn't mention that Patricia is the year's recipient of the Association of Child Neurology Nurses Award for Nurse Practitioner Excellence. Congratulations, Patricia.
Thank you.
Without further ado, I'll pass it over to our most esteemed and dynamic presenters.
Hey guys, thank you for joining us tonight. We're excited to talk to you about some new things that are going on with wearables and technology. We want to do a shout out to some amazing scientists, specifically Glenn Watson at LivaNova, who helped create this beautiful presentation. We're just going to go through it and show you a whole bunch of things that we've learned and that we're hoping will come out. Some of the things are available, but not everything is available just yet.
And thanks also to Chilton Harper from EFMNY for helping to set this up. We really appreciate it. Okay.
Wait, hold on, I gotta make the thing go. Why is it not going?
The problem with doing these webinars is you never know where to click for the next slide.
Oh,
now
too
much. Is that the first one?
Hold on, let me go back for a second.
Okay,
There we go.
So tonight we're going to talk about a few different things, and most importantly is wearable devices. So as clinicians, we struggle with people coming in and asking us, how do I know if my child or my loved one is having a seizure? What is going to tell me? How am I going to know? Especially, how can I monitor while they're asleep? So that's a big need. So that's our first agenda item. So the first is, what are wearables? And we'll talk about the different options available, why we need seizure detection, what devices are currently available, and the current research and challenges that are going on, and the future directions that we'd like to see happen for wearable devices for seizure detection.
Now, what are wearables? So these are things that, are not implanted in your skin, not implanted in your brain. These are things that you can wear and you can take them off. And the goal of them is to detect that there's a seizure, provide some data that you can collect information and data, and then alert the caregivers so you know what's going on. And they come in many different ways.
So there have been a bunch of different surveys of people with epilepsy and the people who care for patients with epilepsy. And they've all talked about how important it is and how disconcerting it is never to know when the patient's going to have a seizure. And then also to be able to just document what the seizures look like. So there's been a couple of large surveys, and there is a real need for these seizure detection devices. What we're looking at now is people who are afraid to have their children sleep alone because they don't know if they're going to have a seizure. We still have adult patients who are still sleeping in their parents' rooms because they're terrified that the patient is going to have a seizure and get hurt or even die from a seizure. And this unpredictability. So it's not only the fact that they're having seizures, but it's that you never know when one is going to happen. And you control all these variables to make sure that they won't have seizures. So you have rescue meds, you make sure they take their medications on time, you make sure they get sleep, you make sure they eat, and yet people still have seizures when you don't know about it. And it makes it very, very difficult for the patients and for the families to be able to go out and live a life. You don't know if you're going to have a seizure when you're touching the stove or in the shower or walking across the street. So it makes people stay at home and do nothing, and that really impacts on their quality of life. So we really need something that will be able to alert us to a seizure and maybe then to also track when the seizures are occurring. And that kind of data can help us with meds and surgical options going forward.
And what Patty said is really important. Even us as medical providers, we really need to know how many seizures people are really having. And these devices really allow us to collect that kind of information. So this automated seizure detection, being able to count actually how many seizures people are having. Because people come into our office and say, yeah, I had a few. How many last month? 2, 5, 10? I mean, it makes a difference because that way we know how our medication is working. So sometimes the reliability, the mother says, well, they were hanging out with dad and I think dad missed a few, or, hanging out with the nurse and the nurse missed a few, or hanging out with their friends. So it'd be really nice to have that kind of real data. It's also important that the seizure detection is able to alert somebody else since the patient's not really able to make a telephone call, and also give some warning of when to give medication early on if a seizure is going on for a long time. A lot of times parents will say, well, I came in, they were having a seizure, but I didn't know how long it was. So should I wait my 3 minutes once I start seeing the seizures, or do I assume that the seizure is already going on before I heard the noise and then go ahead and give the medication? So this might bring up the whole idea of decreasing morbidity, mortality, which is risk of injury and of course death, because we might be allowed to provide treatment even sooner. And again, objective seizure identification and quantification means that we don't have to rely on some observer counting the number of seizures over a week. We have some real hard data that things like that all of us neurology folks like to know.
All right, so they're especially needed for people who have generalized tonic-clonic seizures. So there's two distinct groups of seizures. One are seizures that arise in one area of the brain and can spread, and the other are generalized seizures, so the whole brain sort of lights up with the electricity. The major risk factors for SUDEP, or sudden unexpected death in epilepsy, are the risk of those who have increased generalized tonic-clonic seizures. So most of the people, when we went back and looked at SUDEP, or sudden unexpected death in epilepsy, and there's been a lot of research recently, the majority of the cases that had video EEG documentation occurred after a generalized tonic-clonic seizure. There were more SUDEP cases with increasing generalized tonic-clonic frequency, and the risk of SUDEP is 27 times higher in those patients who've had one generalized tonic-clonic seizure during the preceding year. So even worse than this is what you think about. Oftentimes these seizures occur in sleep. And as people get older, people with epilepsy may not be sleeping in the same bed with somebody else. They may not be sharing a room. They may be in a residential facility. They're certainly, hopefully not sleeping with their parents, although we do have people who still are. And if you're not in a bed with someone else, a lot of the seizures can go undetected. So if you look at this, research studies that were done, so the combination of not sharing a bedroom with somebody, not having anyone who's going to hear or feel if something goes on, and having one generalized tonic-clonic seizure a year has a 67-fold increased risk of SUDEP.
But just to back up one step, just in case you've never heard the term SUDEP. SUDEP is sudden unexplained death in epilepsy. I know that sounds horrible and scary, but if you really look at the incidence, it's 1 in 2,500. So actually you have a higher chance of getting hit by a taxi while standing inside a lobby of a building in Manhattan than this happening. So this is not often, this is rare. We know that SUDEP can happen, but the way to minimize SUDEP, of course, is taking medication, getting plenty of sleep, and anything else I can think of?
Nope.
Okay. So I just don't want you to, if you haven't heard that term, I wanted to sort of explain that to you. So what Patty was also talking about with generalized tonic-clonic is that we know that 25% of people who have generalized tonic-clonic seizures also have a higher risk of serious injury, fall, hitting your head, requiring hospitalization. So again, the real important thing is to best control generalized tonic-clonic seizures. And of course, that's with medication and speaking to your medical provider.
All right, so what do we have that's available right now? A lot of people are using the old child alarms that are in the bedroom. Some of them have video, some of them don't. So the things that you used to put in your baby's room at night. So more of them have videos now, but then parents are spending the whole night awake staring at the video to make sure the child is not seizing. And some people have the Nest devices so they can watch the child in sleep. But what we really want is something that's going to alert the family member or the caregiver when the child or the patient has a seizure. So right now, the 3 types of things that we have are smartwatches. So these are similar. They look like an Apple Watch. They're very popular and they detect heart rate. So an increase in heart rate, a decrease in oxygen saturation, an increase in skin temperature and skin conductance, accelerometry, I can speak, and electrocardiography, which is still in development. So they look at changes in the heart rate, changes in oxygen, changes in skin temperature, all these things that change with an active seizure. There's another one that is a smart ring. So that's a ring that you wear on your finger. It's like a smartwatch, but they have different movement artifacts. And some of the problems with some of these devices are that if you move or if you're waving your arms around, they can go off a little bit too easily. So they're working on making that better. So smart rings, smart watches. And then there's another one that's an armband, which is a sensor. And we're going to show you pictures of all of these. So it's a band around the upper arm. Some of them have adhesive stickers and then a piece that goes over it. And these can do the same thing. So they monitor heart rate, muscle activity. So if you're shaking and having a tonic-clonic shaking, relaxing seizure, oxygen saturation, skin temperature, again, accelerometry. So the same variables, they're all a little bit different.
So smartphones also have some ability to sensor, but most of the time, the 3 devices that Patty just spoke about need to be connected to a smartphone. So it can pass on the information to a loved one. There are some new ones that are out where it has little stickers that you sort of put on at night, either behind the ear, back of the neck, that are also connected to a smartphone. So it could check maybe even brain waves or looking at muscle conduction. There's some other ones that are getting, such as glasses, armbands, chest bands. These things are coming out. Again, this is not all commercially available, but the world is opening up and looking for more varieties for us.
Now, while we're talking about that, I just want to go back for a second. When they talked about the little things that went on the glasses, it's very important that everybody has a med alert bracelet or some sort of information so that if they have a seizure, people that find them, EMS, police officers, will know that they have seizures and be able to identify them with some of the contact information in it. What made me think of that was the little thing that goes on the glasses, because there are little patches that you can put on your watch band. There are things that you can stick on your phone. And then there are the usual bracelets and necklaces that you can use. So that is very important in addition to the alarm devices. So what do we have now? We have some non-invasive wearable devices that we've just gotten approved. They've really very recently come out. So if you look at this schematic, the red dot shows the ones that are approved and available to use now. The blue is the benchtop, so that means that it's really in research and they're just really looking at it now. The green are consumer grade available, and the yellow are still doing research. So, and again, these things, depending on where they are, they measure accelerometry, which is the speed of the muscle changes, EKG, skin galvanization, which is the electrodermal activity. There are some that read EEG, so there are ones that are sort of mobile EEG devices. And then, of course, there are the implantable devices into your skull that will measure whether you're having seizures, and then temperature and EMG. It's a good overview.
So this is a horrible slide in the sense it's a great slide.
It's a great slide.
Horrible in the fact that it's just small, and us old people, it's hard for us to see. But basically, there's a lot of companies that are working on a lot of different things. And right now, I don't think there's a dominant one that's right for everybody. But there are a lot of options that are going to be out there in the next few years. That being said, this is probably the most common one.
This is the one that we write prescriptions for all the time, and it does have its drawbacks. This is the one that I said looks like a smartwatch. So it's worn on the wrist, obviously, like a watch, and then it is linked to a smartphone. So it goes off when a seizure is detected. So it monitors seizures, sleep. It has an accelerometer, skin temperature. The battery lasts for about 48 hours. It's Bluetooth compatible. You can change the bands, water resistant, but it needs to be linked to a smartphone. So one of the family members' smartphones or the person's own smartphone. It does go off. Sometimes it has some false alarms. We've had patients who are waving their arms around a lot, and that'll make it go off. It is commercially available. It costs about $250. It's covered by some insurances. What we do is we write a prescription for it. You need the diagnosis, the date of birth, and then the family goes and uploads it to the website, and then it is sent out to the house. There are a couple of other things. So there's Smartwatch Inspire, BioAlert, and then MFit. MFit is a smooth pad that fits between the mattress and the box spring on the bed, and it goes off again if there's generalized shaking. And again, we know that's what places you at the most risk, is generalized tonic-clonic.
So a comment about the Embrace Watch. Basically, the patient needs to have their own real phone because it needs to be very close to their body or their head at night when the watch is on. And then there is a learning curve. You really need to practice with it, you know, have them shake it so it sets off false alarm, and you teach it that's not a seizure. So there is a little bit of a learning curve, and you got to keep tweaking and tune it to find what works for your child or your loved one, just so they're not, when they're thrashing in bed and turning over, it's not setting off the alarm. So there's a little bit of practicing that you have to do with it, and having a little bit of patience. But we've had some nice success. So probably the most popular of the commercial ones that are out there. But the most important thing you have to understand is this doesn't always pick up every seizure. And in fact, of all the devices that Patty and I are going to go through, there is no perfect one yet. And you sort of have to figure out what type of seizure your loved one has and which one works best for them. So as Patty mentioned, the pad that goes under the bed, for someone who shakes really hard, that's good. The Embrace Watch is also good for shaking. But I had a family member today who has an Embrace Watch, and the seizures were typically involving the left arm, and now the seizures moved to the right arm, and they want to know, should they have two watches or not have two watches? And the answer is, you don't need to.
The other thing that it's not great for prolonged non-convulsive status. So somebody who's really staring in out of it won't pick anything up. And also complex partial seizures. So people that might be just one limb, as Steve said, one arm was shaking and now the other arm is shaking. You know, so it does miss things, and staring, you know, staring episodes.
This is called NightWatch. This is one of the newer ones. It's a little bit more expensive. And
It's a lot more expensive.
It really focuses on using some cool technology called plasma technology. I can't ever say.
Photo plus this month. Yeah, no, I can't say it either.
Can't say it either. Anyway, what it does is it's able to use optical techniques to look at heart rate and look at motion, and helps to pick up motion movement. So it's a new cool technology that we haven't used on any of our patients yet. It's really just kind of coming out, but it's this whole idea of what's out there. Sammy, which is mentioned here, similar products, is basically your Ring doorbell, but it can detect motion in certain kind of motion patterns, and it will alarm you as well. So all these are really just motion-based devices, but again, very cool technology that's out there.
One other thing to mention is that the things that stay on an arm or a wrist, patients may have difficulty wearing them, especially if they have some sensitivity to touch. So some of the autistic population really, it's not going to tolerate these things, which makes it a little bit harder.
So that's why things like the Sammy, where there's nothing on you, might be better for certain patients, because there's no question a lot of people just rip off the watch at night, and that's what's
just like they rip off their EEG electrodes at night. Good.
This one is called Brain Sentinel, another really cool device that's really more focused on muscle. So you have this electrode patch, which is a sticky patch. You put it on each night, and you have this little device that clips onto it and basically measures for motion. And then it just alarms off. What's nice about this one is you don't need a cell phone or a watch. It just alarms, and but you know that there's something going on here. We don't have the prices, but these are now commercially available just recently. They're pretty cool. And again, you got tailored to your kid.
So this is the brain patch. So this is an EEG device. So it acquires at-home EEGs. So you know how you have video EEGs or ambulatory EEGs that you go home with the electrodes on. These are much smaller sensors. You can see behind the ear and in the back of the neck. So there's small wearable devices. Then they also measure brain, heart movement, and muscle activity. You need a prescription for it. We haven't used this at all yet.
It literally just coming
It
out.
just came out.
The problem is you got to adhere it on. You need someone who's not going to rip it off and pull it off. So a lot of our developmentally disabled kids and adults are not going to really tolerate it. And you know, there's a little bit of adapting to sleeping with these little extra plugs on you. But I think it definitely has a place in certain populations.
All right, and this is a spreadsheet of all the ongoing research that we're looking at now. So they're looking at mostly EMG and accelerometer data, if you can look at this, and EKG, and they have been testing it in the EMU, which is the epilepsy monitoring unit. For the most part, they're looking at generalized tonic-clonic seizures, but you can also see focal seizures, multiple seizure types, complex partial. And if you look at the sensitivity is all over the place. Actually, the Hepatica is low on the list. And then if you look at the false alarm, so this is what Steve was saying about training the device to detect your seizures. If you look at the Hepatica and the 180 motion, they have a high false positive rate, so that you'd be running, you're running all the time thinking that it's alarming. So you really do have to train them, and you really do have to know your audience. The other thing to remember is that people who are sharing rooms in residential facilities, there is a problem with having a video device in the room with another patient because it can pick up the other patient. So that's a medical legal issue. And then there is the issue with having a child who goes away to college and you have a seizure detection device on them, and then who is the person who's responsible? It can't really be the roommate, can't really be the RA. So that's another kind of fuzzy legal issue just to keep in mind when we all go off and think, oh, this is great, I'm going to get this seizure detector, and then you go and spend the money, and then maybe it doesn't really work that well for social reasons.
So basically, how are we going to integrate wearables into our standard of care? And again, I think this is going to take more of a conversation, and really this is sort of the beginning of the whole world of it. How does it provide really information for us, the healthcare providers, and will it allow us to be more patient specific in using this information? And the data, there's a lot of data there. There's accelerometer, there's cardiac data, there's EMG data, maybe even EEG data. So there's a lot to find. And maybe as we learn this data, it might give us some warning signs that maybe a seizure is coming on for a certain individual. So say you're someone who's building up an aura or developing, and that creates a heart rate and some muscle artifact to build up always prior, half an hour before the seizure. Maybe that will be more predictive for someone else. So all this data is really helpful, because then if your alarm goes off and says, I predict that you're going to have a seizure based on these two factors, maybe you should take some extra medication, and maybe then you can prevent the seizure from happening. So this is stuff that we are just really evolving. So it's not only about detection, but maybe about prediction. So we're waiting to gather more information and to learn about this.
All right, the other things that we're looking at are more wearable devices. So there's been research being done on wearable clothing that will detect seizures. If you think about people who are runners, and they can wear this very specific clothing now that will record how long your run is, how many calories you burned. It's almost like wearing an Apple Watch, and how long did you row? How long did you run for? So it's an opportunity again to forecast seizures with a whole bunch of these different physiological signals. It can be more powerful, as Steve was just saying, if you have the monitoring of the wearable stuff, And then if you can correlate that with behavior and mood and auras and how the person is feeling, we can tailor your epilepsy treatment. You know, it's much more specific than just giving meds.
So this is just going over all the different seizure types that there are, and Patty and I spent a lot of time looking at all these different devices and trying to figure out which modality is the best for each type of seizure. So for drop seizures, because they're so quick, you know, you might not get a big heart rate, you just get motion. If you have, you know, a lot of jerking episodes, your heart rate might go up and you get motion, but, you know, how do you predict that? So, and like I said, every seizure type is different, and there's not a perfect device for each one. And I think as time goes on, we're hoping to find the right one that can gather most of them, or find what's right for your loved one.
It's almost like they started working on the easiest ones to detect, which are the big generalized tonic-clonic seizures. We always worry about tonic seizures because in people with developmental disabilities, those are the ones that last the longest, I mean, in periods of time. So as they grow into adulthood, there's always more of a risk of these tonic seizures, which often happen in sleep. So our research has sort of been focused on recognizing tonic seizures, and there is nothing yet that recognizes that. There are some new seizure detection devices that are being worked on. So if you look, so take tonic, which is my pet problem. So you just get stiff. And the first thing is to be able to look at the EMG. So that's the muscle contractions. And that's harder to measure. So there's nothing that's been out for it yet. Accelerometry, which is how fast you move and how fast the tone changes. So that's great for clonic and myoclonic. So the clonic are the shaking, myoclonic are those little quick jerks. Atonic are the drops. And again, it's hard to measure muscle for that. But what they're looking at is EKG changes. So changes in the heart rate, changes in the EEG, which is the brain waves, and then videos. Spasms, so think of infantile spasms where the babies are just having those little quick jerks with their head drops. And that, again, they're looking at muscle movement, they're looking at accelerometry, so the change in speed of the muscles, and then EEG and video. So it's very interesting the way that they've spread it out here to see which things would be appropriate for each type of seizure. You don't want to develop a device that you can really only use in one kind of seizure. So you have to integrate all those parts, but maybe in the future, they'll be able to say, you know, this patient has more atonic seizures, more drops. So let's focus first on the EKG and second on the EEG, and their generalized tonic-clonic seizures are more rare. So we can down the road have the EMG and maybe sort of coordinate them for different levels based on different types of seizures.
So,
big ask.
So the bottom line is there's much more need for research and development. There are many more projects that are going on. We really need to get these devices to a point that they work reliable for multiple seizure types, and they're good for a broader population of patients, and they don't require as much tweaking and tuning on behalf of the loved ones of the patient trying to find what's available. I mean, what works the best for that patient. So we're getting closer. This is just the infancy of this. So if you get frustrated with a device, don't give up, try something else, and just keep watching for the newest version of these devices and see if they got any better. And again, the most important thing is us doing good quality testing on this in the epilepsy unit, in the home, and really validating and not selling, you know, the Brooklyn Bridge to somebody, because everything has its limits. And also the idea of automated seizure detection or prediction is a huge area, because then we can possibly give medication and treatment in the prediction area to help prevent the seizures when we feel like they're building up. So in summary,
we have a need, which I think you all knew before you walked in here, that we need better seizure detection wearables. And that's both for alerting a caregiver, giving rescue medicine, stopping an ongoing seizure to prevent injury and death. We need to, most importantly, detect generalized tonic-clonic seizures, which all the available modalities are doing. And then we need to have more wearables that can identify other kinds of seizures. And that's challenging, as you saw, that they have to really pick out what they're going to focus on first. We think we'll be able to predict seizure risk And then we have to keep working on performance ID, performance increase or improvement, and really design these clinical validation studies to make sure that they actually do work in the real world. And that's what we need patients for. So we really need people who are willing to try these devices, take part in research. It's the same thing with the pharmaceutical research and the device research. We need people who are willing to put themselves out there for the greater good of all the people with epilepsy so that we can put an end to this disease and help people more quickly, which is really of the utmost importance. So any questions? I see there are a lot of questions in the chat boxes.
Let's see.
17. All right, we're going to pull this up and make it bigger so we can actually answer the questions. Okay, are those, thank you. Are those gummy bears? Yes, they were. They were a prize from the Child Neurology Society in Boston from LivaNova, but now we ate them all. So sorry, guys. All right, hi to all our patients who were there. Hi to Glenn, we really appreciate you doing this. You're going, Steve, you're a little muffled.
I'm muffled,
always
sorry.
muffled. Does health insurance cover them? Yes, so the Empatica watch does cover it. I don't know about the other one that was more expensive, whether that's covered by insurance or not, but the Empatica is.
And is there any of them that are predictive just yet? The answer is no, not yet. Nothing that's just about predictive.
Can it have a connection to multiple smartphones?
So the Empatica, you have to set it up to one smartphone, but it will alarm. You can set it up to alarm multiple smartphones. So the one device that's near the patient is the one's connected to the watch. And then you can have it set up to call multiple numbers and alert multiple numbers. And then you can turn off, say you're going to sleep that night and someone else is going to stay awake to listen to the alarm. You can shut it off, on and off.
They're apps for smartwatch. The Apple Watch has a heart rate detector, but not a seizure detector yet. I think someone is working on that. If you already have an RNS, are those devices more of a detector to use? Yeah, I mean, if you have an RNS, which is a responsive neurostimulator, NeuroPace, that's already, you already have electrodes into your brain that are detecting seizures. This detects the clinical seizures. So yes, you can use them both together.
And it might be useful because it gives you the RNS devices like having an EEG in your head, but it doesn't alert the family. So it might be useful in some cases. It's worth considering. These wearables are great. Yes, there's a lot under research. Okay.
It's good to see our patients here. Thank you guys for tuning in.
Would any of these devices be a good match for a child who's not having actual seizures, but
don't say the name.
Right.
So spike and wave during sleep. So it only detects clinical seizures. It would, so the way that you would detect, you would be able to monitor the spike and wave is by an EEG. So there is no, other than an RNS, there is no other long-term, constantly on detector for epileptiform abnormalities.
So spacing out zoning episodes probably would not be detected at this point by these devices just yet. It's really got to be shaking.
It's not really EEG, short replacing EEG yet.
Shaking, rocking, rolling. Yes, this would work with a VNS. There was a question, and it might be good because then you would know when to go in and swipe the magnet and give an extra stimulation.
Just work with VNS, yeah, targeting movement. Yeah, we talked about the limitations, that it's really just movement at this point.
Yeah, movement is the best detecting parameter of all these devices.
The one for the bed, I don't think you need a prescription. It costs about $200, but it's really only generalized tonic-clonic seizures.
And it's called MFIT.
MFIT, yeah. How do I get a script for it? You call your provider's office and ask for a prescription.
I'm at the bottom here.
That's it? That's all the questions?
You guys are being nice to us, you know? So I hope that was helpful. And of course, you know, go poke your providers.
Wait, I might have found some
more there's questions. Some more questions.
Are you, okay.
I'm not speaking clearly enough.
Will we be sharing the webinar link as well as the PowerPoint off after the webinar? That I will send back.
Yes, they are recording it and they are going to email it out that people can go back and listen to this again for anybody who's missed it?
It will be on our website too. Thank you so much for the question.
Good question. And look at this website. EFA website is great. Another really good website for information is the Child Neurology Foundation.org. Has an epilepsy hub that we've contributed a lot of information to, as well as our books and some of our papers. So you should also look at that Child Neurology Foundation website, as well as our website here for the Epilepsy Foundation.
So the other question is, no, these products don't really help psychogenic non-epileptic seizures because they are non-epileptic.
Someone asked, is it worth
Yeah.
getting a device if the seizures are
They're
well
well
controlled and don't happen often? The answer is not necessarily. It's really up to if you think you're missing something, and you know, you have that little bit of nagging worry, would this be worthwhile? At the same time, we don't want to add stress to someone if they are doing well. You know, the whole idea is this is supposed to alleviate some stress and worry. Parents always say, am I missing something? And most of the time we say to parents, you know, you're going to know if your child had a seizure at night because they wake up in the morning and they're tired, they're exhausted, they have a headache, they just don't look right, almost like a hangover. And that's one of the best telltales. But, you know, a lot of times we're surprised when we do an EEG overnight and we find something going on.
Any other?
Pull that to the side and see if you can see.
No, it's for the complex partial seizures. Yeah, that one is not great yet. It's so nice to see all of you guys. As I'm reading the chat, it's all our patients' name. I mean, you're not all our patients, but
old friends.
Looking for different, better options. Yeah, the partial complex, that, and as well as the tonic and atonic are the hardest to kind of detect. So, you know, more to come. Hopefully, these guys are working really hard on this.
Someone's asking about, I have a VNS and are there other options for focal seizures? And go talk to your providers. There are a number of new drugs that are out there. We have a few studies that are going on and a few studies that are going to open up in children for some new drugs that are coming out. In addition, neuromodulation, whether it be vagal nerve stimulator or neuropace or which is responsive neurostimulation, all this is very exciting, and I'm sure children's looking forward to having another lecture about neuromodulation and some of the work that we've been doing, that some of the other centers have been doing, and the results that we've been having that some of it's not even published yet. So there are a lot of new things coming out, and so please don't give up. Go and talk to your provider. Ask them what else is new and options. If you're, you know, we want good seizure control. These devices are just a band-aid. It's really about trying to find the underlying problem. So just keep asking.
The other thing is that if you already have a VNS, you might still be a candidate for other surgery in addition to neuromodulation. So it's always good to go back and look at other surgical options.
And if you have VNS and you have one of the older VNSs, you should speak to your provider about the newer versions that have night programming, day programming. They have what's called auto stimulation, which has based on heart rate detection. So if you have an old version of the VNS and you had some response, the newer versions, the Aspire, is really super cool. A lot of extra programming and a lot of more tweaking and tuning that we've been able to do for our patients. So go back and ask about that. So a few people asked about VNS.
And then can these still be used successfully if heart rate and oxidation levels change during complex focal seizures? Yes, they can. Probably not as readily, but yes, definitely.
So I hope we gave you a lot of information, and I hope you can take it back to your providers and ask more questions. And also remember to ask them about rescue medications and make sure that you do have a good seizure action plan. Adults and children all need seizure action plans and to have some rescue medication at home. During the pandemic, we did everything to keep people out of the hospital and have a rescue medication. We've done a presentation before on nasal rescue medications. So please go back and ask your provider about those.
So, and there are lots of new rescue medications. Everybody should have them. And there are lots of new medications and new devices coming out. So, you know, don't become complacent. And then the other thing is to share it with all your family and friends and all your contacts who have epilepsy. I feel like sometimes we do these talks and we're just getting a small group of people, and it's incumbent upon all of us to reach out to the wider network so that people do hear that there are other things to do. So one seizure is one too many. We really want to eliminate them.
And next month is Epilepsy Awareness Month, so
wear purple and spread the word.
we have a purple gummy bear.
Thank you so much, Steve and Patty. That was fantastic. If
You are
anyone
very welcome.
has little questions, type quickly before we end. But we also want to thank again LivaNova for their support. This was wonderful. We have a recording. We had about 76 people listening live, and I'm sure once it's up, we will have a lot of people learning and enjoying hearing what you shared tonight. So thank you so much.
All right. Thank you all for coming. Appreciate it. Have a great night. Thank you, Glenn. Thank you, Glenn. Thank you, Chilton. Thank you, Eleanor.
Thank you, Chilton.
And Logan. Thanks.
And Logan. Oh my gosh. Sorry, Logan.
Yes, don't forget Logan. He's
We
priceless.
would not be here without Logan fixing all
No, we
this and
couldn't.
getting all the
We
technology.
need the youth. to
Logan,
keep us
you
going.
can come to my house. My husband needs some help with his computer.
Technology.
So,
Oh dear. All right.
and we have
Thank-
no patience. So
Bye, guys.
bye,
Have a
guys.
great
Be
night.
well.
Bye.
Good
Have
night.
a great night. Take care. Bye-bye.